Hello, my name is Dylan Hoffman, and I'm going to be doing a presentation over manual therapy concept mapping and some of the more common models of thought that we have in manual therapy. And I'll talk about a case that I have and how some of these models fit into what I've done in this previous case. So I want to start off by kind of showing these two models of thought. And one is really diving into the biomechanical model, right? And I think this is the one that a lot of people are familiar with, definitely what I'm most familiar with. And that's I'm going to fix postural imbalances. Now, we've come a long way in our understanding here. And we've gone from we got to get every single person to the same universal perfect posture, and that's really not the case. But what we are seeing is you are seeing everybody can have an optimal posture, and we often get hypermobilities and hypomobilities, areas that move a lot based on our forces and mechanics and the way we move and live our lives, and areas that get really tight, stiff, and just hypomobile in general and don't want to move. And so being able to fix those imbalances or work on that in a way that's going to help and then have some rehab and exercises that make those changes long lasting is really the basis of the biomechanical model. And as I said, it's a theory that the body is a machine. It's a complicated series of working parts that all have to work together. And if one gear in one spot of the chain isn't quite working right, maybe it's moving too much or it's not moving enough, it can affect the chain further down. And so it's really looking at the body in a holistic approach, understanding that the body is mechanical, it is interdependent, and working to make sure it's functioning at a high level. The comprehensive model doesn't dismiss this as much as it attempts to create a neurophysiological response as well. So it says, okay, we have this body, but we have to understand that our body's controlled by the nervous system and our central nervous system and our peripheral nervous system, and we can. The way I kind of interpreted it was I can come in and I can fix all the light bulbs and furniture and everything in the house. But if I ignore the light switch, some of that stuff may not be as effective. And so what this model is saying is that when you do manual therapy, there's going to be some kind of neurological or neurophysiological response to that. And understanding that pain is a neurological or a neurophysiological experience, and understanding the importance and the influence that manual therapy can have on that. So let's dive real quick into this case description. 17-year-old male track athlete, clinically diagnosed with right hip FAI, had pain predominantly with deep squat for about 3 weeks, maybe 4 weeks. Some just kind of noted things so that as we talk about my manual therapy, hopefully this will kind of link in. Noted very hyperlordotic posture, hypomobile thoracic spine, and a hypermobile lumbar spine. Had a right side anterior innominate and shortening of the iliopsoas really bilaterally. So a positive Thomas test on both of those. Extreme shortening of those muscles. And so when we look at the interventions I chose, we can talk through these, but all of these really were looking at what are the quote unquote mechanical deficiencies that I see and how can I fix that. So doing short axis distraction of the hip to try and get some more space in there so that the hip is not impinging. Doing some psoas release, working to get those muscles to lengthen and to relax so that we can work on strengthening and lengthening the psoas muscles. Thoracic, high velocity, low amplitude manipulations, working on the hypomobilities we were seeing at the thoracic spine. Hip mobilizations as well. So working to work on that posterior roll and glide of the hip itself, and then working to correct the anterior endowment that we saw through muscle energy techniques. Coupling that with the therapeutic exercise, because the model that I use and practice with involves just as much or more therapeutic exercise as it does the manual therapy. Pelvic tilts, side steps, bridges, planks, open books, dead bugs, anti-rotation side steps, holding a resistance band or something out in front of them, and doing side steps resisting rotation of the spine there. Really, if you look at these, the two biggest things I was trying to strengthen was the core in general, dynamic strengthening of the core, or static strengthening of the core, and then working on some mobility of the thoracic spine and glute strength, specifically glute med strength. And with the pelvic tilts and a lot of this, the idea was I was hoping to get some type of response and reception from the patient that they would move more into a posterior tilt of their pelvis, keep that posture, therefore kind of opening up and giving a little more space on the anterior side of the hip joint. Once we were able to do some more pain-free movement, he was actually able to kind of do a body squat without pain. We progressed into a little more stuff, kettlebell swings, wall squats. I like the wall squats because he's able to get down into that deep squat, utilize some of those muscles. It's a isometric exercise, yet we weren't really putting the hip in a deep flex state with an anteriorly rotated pelvis. And mountain climbers, resisted marches, really just working on the strength of the iliopsoas there, overhead lunge and single leg TRX squat. Looking at my reflection and how I kind of break this down, I for sure approach this from a biomechanical model. I think a lot of that is that's what I've learned. Just about every manual therapy lesson class that I've ever sat through really goes after that. It's where are we moving too much? Where are we not moving enough? If I have a hyper mobility and I'm deciding that my pain is being generated due to that hyper mobile segment, I'm going to do exercises to stabilize that, and I'm going to do manual therapy and exercises to mobilize the spots that are not moving a lot above and below the injury, and so or the affected area. And so that's really the basis of pretty much all of my interventions. We can look again, except for, maybe the distraction. None of this was really geared towards immediate pain relief. All of this was geared towards fixing what I considered to be some type of mechanical or postural imbalance. And so there really was little to no consideration into the neurophysiological aspects of manual therapy in my case. And when we talk about that comprehensive model and utilizing this, it's really not something I considered. Now, that's not to say that the patient may not have benefited unknowingly to me from a comprehensive model. As we've seen that manual therapy can have effects even with joint mobilizations, et cetera, at the peripheral spinal and supraspinal levels and through those mechanisms. So it's very plausible that we saw some pain reduction coming out of my interventions, but that was never the goal of my interventions. And so that may have been an outcome, but it wasn't an outcome that I was actively pursuing. I was actively pursuing a biomechanical model and was really focused in on that. So overall, that's my case study. The good and the bad of it. On a positive note, the The patient had good outcomes, and overall, I feel good about the treatment plan that was given. Looking forward, I'm really interested in diving more into that comprehensive model, really looking at the neurophysiological aspects of manual therapy, and hopefully being able to incorporate that in, that I'm not doing it without knowing I'm doing it, that I'm actively and intentionally providing those benefits for my patients. So thank you for this presentation. That's all I have.